G'day everyone, and welcome back to the live stream. We are 18 days until exam, and this is generally practicing. So this is a live stream dedicated to help you pass the 2023-2 KFP exam. But of course, if you want to use this for any other KFPs in the future, you are more than welcome to. So we'll meet up every Wednesday before the exam, go through some practice questions and practical tips, as well as try and upload those questions later on for revision or study down the line. For those that don't know, my name is Kane Treble. I'm a GP registrar based out of Mildura, Victoria, Australia, trying to get through the KFP exam myself, and noticed there weren't many resources online, so I wanted to make something that could last for a little bit longer. Let me know who you are in the chat or in the comments, as well as if you find these videos at all helpful, because that's what lets me know to keep making them and to have these resources available. All right. Without further ado, of course, we are here for the content, so let's get to it. We are 18 days until the exam. We have, again, been confirmed that this will be a paper-based exam, so make sure you are actually practicing these questions with pen and paper to make sure that you're able to answer these questions legibly and with sufficient speed and proficiency to get through the full exam. Try and make it a habit then of using bullet points and numbered lists to keep yourself on track. Make sure you leave spaces to, again, improve legibility, but it also means later on, if you want to go back and perhaps adjust or tweak some of your answers, you've got some room to add those details in. And of course, proofread your answers at the end. So you should also have recently been sent through your exam venue details. That should have been in an email from RACGP. And so if you don't have those or aren't familiar where you're going to be sitting your exam, you should be checking your email or contacting RACGP now. Now, we wanted to run through some practical tips today. And if we just go back to our little plan here. I've made a few animations here. Hopefully you like them. We've done a little welcome bit. We're going to go through some practical tips that were noted on GP registrars for RACGP prep that I thought could be particularly useful. Again, just to remind you of some of those little details that you can miss if you're not being particularly careful. And so here they are. So this is Chaudhry S.A. Beg. And who noticed that there were particular things you should be focusing on if you're seeing particular keywords in the statements, those statements being most important. This means that you should be looking at the most serious disorders. This is your do not want to miss differentials. Now, this is opposed to the most likely, which means the probability type diagnosis. This is again kind of thinking back to that Murtaugh model. For initial, and often that's initial investigations, these tend to be the more simple, first-line, inexpensive tests that you can do rapidly to at least exclude or include big differential diagnoses. Best means they're after the definitive or gold standard kind of diagnostic tool. And of course, immediate means what are you going to be able to do for that patient if they were actually sitting in front of you right there and then? What is the most important life-saving action to be taking? Hopefully that makes a bit of sense to you all. I saw that and just thought, wow, that's a really good, really succinct way of getting that very important information together. And so I thought I would make sure I pass that along tonight. Now, you can probably hear my voice is a little bit different. I have had a cold this week, so bear with me. I am trying to get through. I should have made some honey lemon tea. If we are ready then for our very first question, and hopefully you all are, we will have 2 minutes on the clock. This is our first practice question, so make sure you've got some paper and pencils or pens ready. 2 minutes on the clock, your time starts now. John Anderson, a 55-year-old Caucasian man, presents to the general practice with complaints of persisting cough and shortness of breath for the last 3 months. He reports occasional wheezing and chest tightness. He is a lifelong smoker, currently smoking 1 pack of cigarettes per day. He has a history of hypertension, for which he takes amlodipine 5 milligrams daily. He has no known allergies. On examination, John appears breathless and has audible wheezing and oscillation. His temperature is 37 degrees Celsius, blood pressure 138 on 85, heart rate 90 per minute and regular, respiratory rate is 22, saturations of 96, and BMI is 26.3. The remainder of the examination is unremarkable, but is the most likely underlying diagnosis for John's symptoms based on the given information. Provide 3 appropriate responses. All right, how did you go? Again, so you can see kind of my technique I like to use. It's all about making sure I'm locking in the best information possible to make sure I've got the best chance of actually answering that the question that's being asked. So again, this is what is the most likely underlying diagnosis based on the given information. They want 3 appropriate responses. Now immediately I'm making sure that I'm going to be only providing 3 appropriate responses, thus 1, 2, 3. I'm getting that list out there so that I know I'm going to be giving those responses and not giving any more. Avoiding overcoding. I tend to underline the important bits of information that I think might be pertinent to the case. And let's have a look at what some answers might be. So, this is, I think, a case that's screaming out for COPD, chronic obstructive pulmonary disease. Again, remembering that we are wanting to avoid using abbreviations whenever possible. Now, it is clinicians marking these exams, and so there is a little bit of common sense leeway. However, they have stated again and again, if you really want to make sure that there's no risk of missing out on marks, make sure that you spell out any abbreviation that you might want to use. Now, again, I probably would want to know more about he's smoking 1 pack of cigarettes per day. Well, what size pack is that? But I think the overwhelming information here is leading us towards that COPD pathway. Of course, this could be asthma, not impossible, a bronchitis picture, so inflammatory changes and leading to narrowing of the airways, producing that wheeze. There could also be lower respiratory tract infection or a community-acquired pneumonia. The time frame is a little bit off, but remember we can see changes in the chest from pneumonia for 6 to 8 weeks after initial infection as well. And of course, we do have that big smoking history, and so one mark that is a relatively safe bet for these kinds of questions would be to include malignancy of some shape or form, and so in this case, airway malignancy would be a good kind of catch-all. Whether they would accept that or a specific example, such as bronchial carcinoma, would potentially be up to the assessors marking it. How did you all go? Let me know. But of course, we've got more questions than that. So, without further ado, let's put another 2 minutes on the clock, and of course, your time starts now. What initial investigations would you consider to confirm the diagnosis for John? Provide 3 appropriate responses. right, so how did you go there? Let's go through then to some of the answers, and for here, again, focusing on the fact that we are after the initial investigations, but they have kind of given us a bit of a trip by saying confirm the diagnosis. So again, we're presuming they're going to be taking us down that more COPD kind of pathway, and so ultimately the best one here is going to be spirometry with or without DLCO, and I think really as long as you're getting the spirometry there, that's going to get you the 2 marks. Thank you, Demir. Some excellent answers coming up there. Again, the chest x-ray, fantastic. Again, remembering these are the initial initial investigations. And so you probably wouldn't jump straight to CT chest. Certainly if there was other things down the line that required that kind of imaging, you would then progress through to that there. You have put down the sputum analysis, fantastic, very appropriate. They would also accept something like pathology. And I think you would need to have some kind of sensible answer and some kind of rationale as to why you'd be ordering that specific one, but it certainly would be considered. Now, again, excellent answer there from Samir. And I will just say, just be careful and make sure we are answering the question asked and providing 3 answers when requested to make sure you actually get all the marks there. And, sorry, it looks like you're getting a bit of blurring of the screen. Hopefully it's not a connection issue. You can try and click the little cog icon in the corner and see if changing the resolution setting there gives you any benefit. Just having a look. I am getting excellent connection from my end, so hopefully no troubles. Demir, if you're having some issues as well, please pop it in the chat and I'll see if I can tinker from my end. But of course, without further ado, let's get to another question. And looks like that screen's okay. So yeah, Samir, play with the gear icon, see if we can't get some improvement there. Now, question 3, we'll put 2 minutes on the clock and your time starts now. His condition settles and further testing confirms your primary differential diagnosis and classifies it as mild. What initial management options would you recommend for John's condition? Provide 3 appropriate responses. Dosing is not required. All right, hopefully you got some good answers there, and I am seeing some fantastic answers coming through. And so here we would be looking at starting a short-acting beta-2 agonist such as salbutamol or a short-acting muscarinic antagonist such as ipratropium. These would be aimed at relievers, given we have this classification of mild, and this is based off the COPDX guidelines. So this question is presuming that we do know what the diagnosis is and that we are familiar with the appropriate guidelines to use. And fantastic that you've linked in to pulmonary rehabilitation as well, or an appropriate exercise program is one of the pivotal aspects for COPD management. And of course, never forget smoking cessation, as you have put. Again, that's going to be one of the big ticket items, so with 2 marks for this question, because it's never too late to stop smoking, and so encouraging that and showing that there can be benefits is definitely worth taking the time. Now, they would also have accepted things like immunisations to appropriate things such as influenza or pneumococcus. A COPD care plan or a GP management plan would be also accepted in this instance, and referral to Lung Foundation Australia or an appropriate support group or psychologist for self-management and support, given the potential psychological impact. Now, we have a question in here about just wondering, would all the answers be accepted, as the question is asking for initial management. Now, for this, you would only put down up to 3 potential answers here, and you'll often find for these exams there are going to be more steps or more potential answers than you have spaces to give you some flexibility into what your particular approach would be and how you would potentially prioritise. The way they kind of make sure that the high ticket items get further priority is through having things worth more marks. Now, in terms of would these all be appropriate for initial management, I think definitely, in particular for something like a first diagnosis of COPD, this is something that you are going to be doing multiple things in pretty rapid succession to get that patient motivated to regain as much of their health as possible. So certainly going through COPDX guidelines, these are the recommendations, and that's why I've fleshed this out as so. But excellent question. So popping up the guidelines here as well. In fact, let's make those a little bit easier to read. For those who do get tempted to start them on some of the LAMA and or LABA combination therapies straight off, for those that have been diagnosed with mild disease, the initial first management would be more appropriate to start with the short-acting reliever medications. But of course, if you're not getting any response or relief to that, that is when you would bring those in. And that is not a trap, but I think a common little situation people find themselves caught up in, and is a potential stumbling block for a question like this that's asking for that first line management. All right, ready for another question? We'll put 2 minutes on the clock, and your time starts now. Sarah is a 42-year-old woman of South Asian ethnicity presenting to the general practice, complaining of fatigue, weight gain, constipation and cold intolerance. She also reports dry skin and brittle nails. She has noticed gradual enlargement of her neck over the past few months. She has no significant past medical history and takes no regular medications. On examination, Sarah appears lethargic and has a palpable thyroid gland with a firm consistency and no nodules. Her temperature is 36.6, blood pressure 130 on 80, heart rate is 60 and regular, respiratory rate is 14, BMI is 29.7. The remainder of her examination is unremarkable. What is the most likely underlying diagnosis for Sarah's symptoms based on the given information? Provide 2 appropriate responses. All right, how did you all go? Some good answers coming through. So let's have a look here. And Hashimoto's thyroiditis is the most likely diagnosis here. And I think they would also accept primary hypothyroidism, and hypothyroidism would probably get you just 1 mark, less marks because it's less specific. Remember, we're trying to be as specific with our answers as possible. Iodine deficiency can technically cause it, and of course subacute thyroiditis. So excellent answers there from Demir. Now, we also have, of course, some answers here from Samir. So Hashimoto's thyroiditis, fantastic. And from BDE, primary hypothyroidism, secondary hypothyroidism. I think I would just be a little bit cautious with secondary hypothyroidism because I think they would also have some other condition involved there that would then be promoting that hypothyroid picture. And given there doesn't seem to be anything else at this stage, I think you would probably have more success going with some of those other answers, but definitely something we'd be keeping in mind. Now, of course, how do we differentiate between all of those things? Well, it's almost as if we had another question lined up. Let's have a look. We'll put 2 minutes on the clock, and of course your time starts now. So what additional features of history would help confirm your suspected diagnosis? Write 4 additional features of history. All right. Hopefully you've got some great answers coming through there, and I'm seeing plenty popping up onto the screen, so very well done, guys. Again, this is really pointing towards that hypothyroid type picture, and so we're going to try and tease out, well, what are all the different potential symptoms or features of hypothyroidism that haven't already been listed? Remembering this is asking for additional aspects, additional features on history. So this is one of the great mimics. It's one of Murtaugh's favourite conditions because it could be absolutely anything, which is fantastic for us because they're asking for 4 things and we have an absolute plethora to choose from. So coming through, we've got menorrhagia or irregular or heavy menses, fantastic. Family history of autoimmune or thyroid disease, fantastic. Any past exposure to radiation, chef's kiss, low iodine in diet. Now, that would be one that I don't know if they would necessarily mark because it's something that I'm not entirely sure many people would be aware of, but we'll see how that would go. Again, we've got family history of hypothyroidism, other autoimmune disease history, such as type 1 diabetes. I would just be... I think that probably would get you a mark, given there are associations there. Low dietary iodine, again, we've already mentioned. They're unlikely to necessarily know that. History of neck radiation, fantastic. We do have mentioned here prior different bowel motion changes, e.g. loose stools. Now, they have already mentioned the constipation, which I think you've picked up there. And so again, that would be going back to making sure we are reading the question being asked and making sure it's not one that's already been given. So it's a very common little trap that they like to play on us and keep us on our toes. Certainly though, eye symptoms such as blurred vision isn't on here, but is actually, I think, a very valid thing to be mentioning. Lower limb swelling, I don't think there was mention of that in the STEM. Generally, that kind of mixed edema picture tends to be with more severe cases, and certainly not impossible, but I think I would probably go for some of the other questions more preferentially. Yellow pigmented deposits over tendons, again, I think would be associated with more severe disease. Now I can see there you've got popping up on here. Hashimoto's usually gets hyperthyroidism symptoms first. Correct. So again, I think you've hit the nail on the head already in terms of maybe it wouldn't be a good idea to try this answer because, and it comes back to when they write the stems, they try to give you all information you need, and I suspect they're really trying to push that hypothyroid type picture, and I'd probably focus there. But you are correct in that Hashimoto's can have that initial hyperthyroidism picture, and so you could ask that, but I'd probably focus on other hypothyroid symptoms preferentially. All right. Now, there is, of course, a part 3 to this question, as there is to every KFP question, so your time with 2 minutes on the clock starts now. What initial investigations would be most appropriate for Sarah? Select up to 4 investigations. All right, so again, seeing some fantastic answers coming through, and the answers provided. So D, K, M, and N, and we have coming up D, I, K, M, and N. Now, the antithyroglobulin levels are a little bit of a trap, and that is, we'll talk about that in a minute, actually, because that's one that is coming up a little bit frequently. We have an ADKM. Yep, so again, would have gotten several marks in there, and we have T3, T4, TSH, antithyroid peroxidase antibodies. Okay, now I've actually written this out to make sure I get this correctly because it is a little bit of a tricky one and is something that I think catches a lot of people out. So initial screening is the TSH. So I'm glad to see everyone had that one in there, and everyone gets that mark for K, which is fantastic. Now, normally would say if it's elevated, repeat in 2 to 8 weeks with the free T4 level as well. But given we have this patient who is quite symptomatic, I think it would be fairly reasonable to send off the T4 at the same time. Again, if we do have these kinds of features, the patient is particularly unwell, we know that the most likely culprit here is going to be Hashimoto's thyroiditis. Now, the TPO, thyroid peroxidase antibody assay, is sufficiently sensitive and specific to make this now the only recommended test to confirm the diagnosis of an autoimmune thyroiditis. Anti-thyroglobulin antibodies are considered to be much less specific and are now only really recommended for monitoring post-thyroid malignancy cases. Now, if you were to go on, we would recommend annual thyroid function testing recommended in euthyroid patients who have positive anti-thyroid antibodies, given we know that progression to hypothyroidism is more common in that patient group. It can be, we know that generally 10 to 15% of patients, even without any symptoms or features, can have those anti-TPO antibodies. And so for this, we'd have our anti-TPO antibodies, and this is one of those little traps that RACGP does like to play on us from time to time, whereby we have a female of potentially reproductive age, and we do know that thyroid conditions are often exacerbated in the setting of pregnancy, and so one thing they always like to send off is a beta-HCG. Now, this is particularly important because it has such obvious implications for pregnancy, given you really have to tightly control your TSH level in pregnancy to make sure it's safe for both mum and baby. All right. How does everyone feel about that? Throw some comments in the chat, but otherwise we will get moving along to our next question. Now, we will put 2 minutes on the clock, and your time starts now. Michael Thompson is a 68-year-old man presenting to general practice with complaints of frequent urination, especially at night, urgency and a weak urine stream. He has also noticed intermittent blood in his urine. He has a history of hypertension and type 2 diabetes, for which he takes metoprolol and metformin respectively. On examination, Michael appears generally well. Abdominal examination is unremarkable. Digital rectal examination reveals a smooth and large prostate. His temperature is 36.8, blood pressure is 140/80, and heart rate is 72. Respiratory rate is 16, and BMI is 27.5. The remainder of his examination is unremarkable. Oh, and these answers already up there. Well spotted. So, in the interest of time then, don't you love it when best laid plans fall apart? So this would be a case where they're leading you towards that BPH kind of picture with lower urinary tract symptoms. In fact, let's just skip ahead to here. Now, the other things that you would be wanting to keep in mind with hematuria is going to be prostate malignancy. Particularly in this age bracket, we have an older male who is going to be at high risk, particularly with these issues of weak urine stream, blood in the urine, and the increasing nocturia, particularly with urgency. Something we, of course, can't rule out would be a simple urinary tract infection. And so, again, we're going to the probability diagnoses you'd want to rule out, and that's a simple one we can do. Now, urolithiasis or kidney stones or bladder stones can also be another cause for hematuria. Now, they haven't specified that there's any significant pain there, and while you would normally expect to see pain, and usually not insignificant pain with kidney stones or bladder stones, you can actually have these kinds of responses in the setting of urolithiasis. So a more painless setting, but presenting with hematuria. And of course, we're getting into that age bracket as well, where it's potentially more likely to be presenting with urethral strictures, and one of the complications over time can be hematuria and bleeding. Now, we do have a question pop up there. Whoop. Sorry. Helps when you hit the right button, hey. About, would prostatitis attract a mark for this question? Now, one of the things you would certainly expect to see with prostatitis would be tenderness on palpation of the prostate on the DRE, and they haven't specified that, and so I think it would be significantly less likely to be prostatitis. If there was mention of tenderness, then I think you would be more likely to get the mark for there, in particular if there was any talk of penile discharge on palpation as well. But given they haven't mentioned any of those things, the probability diagnosis places that less likely. All right. Now, I'll just quickly have a look at the next screen. No, good. I didn't put the answers on that one. Trying something new. Let's try it out. Crazy talk, I know. But let's put 2 minutes on the clock. And, of course, your time starts now. You perform a urine ward test which is positive for hemoglobin 3+, but otherwise normal. What initial investigations would be appropriate for Michael? List 5 investigations. All right, so some awesome answers coming through. And this is another one of those situations where there are, again, more possible correct answers than you have options. So they often do give us that little bit of wiggle room in case there is some variability. And sometimes there are just more appropriate tests to be ordering than the options they give us in terms of answering those questions. So we have CFIKO. Now, this is one trap where we have to consider our risk stratification. So in this situation, we have someone who is 68 years old, and so they're going to be in that higher risk bracket for urothelial or bladder malignancy. And so in that setting, it's actually recommended to move straight to the CT IVP, CT intravenous pyelogram. Now, for some reason, the college always harps on about, avoiding abbreviations, and yet they are always happy to use CT. Now, if you are writing out the answers for, say, a written answer, I would be specifying computed tomography, intravenous pyelogram. Don't get too caught up on spelling. Your spelling doesn't have to be perfect as long as you can get the vague intention across of what it is you're actually trying to write. Now, we also had ACFKO. So yes, ACF. Full blood count, while you certainly could do it if you had to choose from some of the other options, I would probably be switching to other things. And for urine cytology, fantastic. And of course, ACFMO, well done. Smashing it. Well done to all of you. Now, I want to point out with the cytology as well. Oh, pardon me. Sorry, guys. So cytology does have a high sensitivity in the detection of high-grade bladder tumours, in particular your CIS. It has low sensitivity for low-grade tumours. And so as such, it's not recommended for a sole diagnostic tool, but can be a helpful adjunct for anyone that you're going to be considering referring on for cystoscopy, which is obviously going to be this kind of presentation. In particular, if they do have those additional risk factors for CIS. All right, now moving on then to the final part of the question. 2 minutes on the clock, your time starts now. Your investigations return positive for urinary tract malignancy. Michael is distraught and asks if there was anything he could have done to prevent this. You discuss his potential risk factors for urinary tract malignancy given his hematuria. List 4 specific risk factors for urinary tract malignancy in patients with hematuria. Okay, time is up. Let's move on through to the answers, and loving your answers coming through. So, as you've got down there, so age is going to be one of our first things, and they'll find that they'll tend to put down age 40 or age 50. It really depends which guidelines and which kind of patient demographics you're looking at, and so advanced age or older age would be a perfectly acceptable answers. 100% correct in terms of dye exposure, and I really love as well that you were nice and specific there, giving a specific example by saying the dye, given that is a very well-known association. History of cigarette smoking, history of pelvic radiation, definitely, and older age. So very good answers there. Also seeing coming through, age more than 40, smoking, exposure to chemicals, family history of urothelial malignancy, definitely to all of those. Now, I would just be mindful, exposure to chemicals, if you can, again, being specific, trying to focus in, if you know an example, give it, but you're more likely to get a full mark over, say, half a mark or 2 marks rather than 1 mark by specifying an example in your answer. And coming through, we have the abdominal radiation, smoking, family history of kidney, bladder cancer, chronic inflammatory state, e.g. lupus. Yes, now more than just that though, I think you could specify history of chronic UTIs. So local irritation, local inflammation is also going to be pro-oncogenic, and so you can actually just specify that down. Now, a couple of ones that didn't get mentioned there is, of course, cyclophosphamide exposure. It is one of the things we look out for in any patients that have been exposed to cyclophosphamide. No, that's it. You guys smashed all the other ones. Of course, history of gross hematuria and irritative lower urinary tract symptoms are also those red flag tickets into there. So, guys, well done. A gold star goes to all of you, and good job for getting it through all 3 questions tonight. Now, if I can just borrow another minute of your time, you've been very generous with me tonight. I'm keen to get some feedback and find out, if you're finding these helpful, and if so, consider subscribing, because that's what's letting me know whether or not I will continue to do these. I know the questions aren't perfect. I know the formatting isn't perfect. Some would say sometimes the answers are on the screen where they shouldn't be, but I'm trying to build up a bank of resources that I can just have open and free to anyone, given I know that there isn't a whole lot of resources that are free out there. So any feedback is greatly appreciated. Throw it into the chat, throw it into the comments below, and I'll always try and get back to each and every one that writes on. Now, of course, I'm keen to also have another live stream after the exam. It'll be scheduled in 1 week after the exam, same time, to try and catch up with everyone that has joined in, celebrate and or commiserate, and have a chat about whether or not these kinds of questions are useful. And even just to say hi to each other and give everyone a pat on the back. Even if we don't succeed, just surviving the exam is definitely worth celebrating and acknowledging all the hard work that you've put into it. And then, of course, we're into the long wait before we actually get our exam marks back. Having chatted to those involved in the process, it is a very long, drawn-out process, and that actually works in our favour because it's also showing that they're actually going through the marks, making sure that what they've put as the answers align with what everyone's actually coming back with, and it is very, very, very common for the answers that are provided, as you've seen even tonight. If people are giving answers that are appropriate and accurate, but they're not on the marking rubric, they go back, they revise that question, they add those to the marking rubric, and then they remark everything again. Doesn't that sound like fun? Now, there will be plenty of sessions before exams. Don't worry. These are still going to be going on every single Wednesday, so you're stuck with me for a bit longer. Don't worry about that. And, of course, I am also trying to keep in touch with everyone afterwards as well by creating a, dare I say, email list. So I've got the link down there, generallypracticing.ck for convertkit.page/join. Link should also be in the description below. So if it's something that you would want to follow up on or keep in contact, please jump on there. Now, I will open it up as well to a bit of general question and answers. So we do have a question here about tips on time management. First thing I want to say to there is you're already absolutely smashing it. So in the actual exam, remember, we've got 26 cases, each usually in 3 parts, and 4 hours total. So 3.5 plus half an hour, which makes it the 4 hours total. This means you have roughly 2.5 minutes for each question, which then also gives you a little bit of buffer to try and get through at the end if you're very, very quick, which is also why I've tried to make it 2 questions on the clock for these practice questions to give you even more buffer at the end. And very happy to say each of you tonight and every time I've seen you guys answering these questions, you're getting the appropriate number of answers in that time frame. So I think you're actually doing quite well. If you're doing practice exams and finding time management to be something you are struggling with, do try and set a little stopwatch or timer to beep every 2 minutes to give you that prompt to move on to the next question. Add a little star or work out what's going to work for you to flag that question so that at the end, when you do go back through, you know, to spend a bit more time on that specific question. Excellent. Hopefully that answers your question there. Now, of course, if you do have any other questions, feel free to throw it in the chat. We'll try and get to it, if not tonight, then at the next session as well. I am actually also trying to write I know it sounds cringy, but I'm actually trying to write a book that goes through all this process from beginning to end, highlighting all the little tips and tricks that I wish I knew when I first sat down to try and study for this. And I'll be making that free and available to anyone that wants it as a download, which will be attached to all these videos. It probably won't be out by the time we sit the exam, sorry, but will be an ongoing resource that if you know anyone that will be sitting in the future, you can point them towards this channel and it'll always be available. Now, hopefully you've all had a great day, had a adequate evening, and we will be getting across to end the stream. So thank you all for joining me. Again, we'll be meeting up back here Wednesday, 8:30 p.m. for the next session. And of course, we'll only be 2 weeks from the exam by then. There'll be a few extra questions to smash through, as well as a couple of extra tips. And I look forward to seeing you all there. See you guys. It has been a pleasure.